Welcome to this Clinic Conversation of the Week, a series where we explore how to discuss the latest groundbreaking research with our patients in clinic. My name is Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. And today I'll be discussing a piece by Dr. Carlo Perica and colleagues in the New England Journal of Medicine entitled CD4 positive T cell lymphoma harboring a chimeric antigen receptor integration and TP53. It was published in the New England Journal of Medicine last month in February 2025. So this is not a large prospective clinical trial. This is actually a case report. And for a case report to get into a journal as prestigious as the New England Journal of Medicine tells you that it's an important topic. And in brief, it pertains to a topic that has been a huge issue for us in the CAR T, in the immunotherapy field, in myeloma, lymphoma, leukemia, et cetera, for the last 1 to 2 years. And that's this question of second primary malignancies or other cancers following CAR T therapy. I think those second cancers can fall into two categories. There is the category of just cancers that patients who have received CAR T may happen to get later in life. And secondly, there's the category of T cell lymphoma, so actual cancers of T cells that may or may not contain the actual CAR, the gene put into them that was used during the CAR insertion process. In brief, how I talk about the topic with patients, right? Because the FDA now has a box warning on all CAR T therapy products across all malignancies, saying that patients may be at risk of second cancers later in life. For many of our patients, it's not new to them, right? Anyone who's ever been on lenalidomide or ever gone any kind of transplantation, they've been told the same topic before. And I often start by discussing with patients that there is some element of immortal time bias, meaning that if you live long enough with your first cancer in remission, you are at risk of a second cancer developing that may or may not have happened anyways, or that may have happened as a result of the prior treatments you've been on. An example with CAR T therapy, in the CARTITUDE-1 study of ciltacabtagene autoleucel in multiple myeloma, patients on average had gotten 6+ prior lines of therapy. Of the 97 patients on that first trial, 10 of them went on to get myelodysplastic syndrome, MDS. 10 out of 97 seems like a huge number, and it is, but it's worth noting that those patients, if they hadn't gotten CAR T therapy, would have all died of myeloma, and many of them had gotten prior lenalidomide, prior transplants, etc. And so if you imagine, I have to use my hands for this, if you have patient number one who lives and doesn't get CAR T and dies here of myeloma, and this patient gets CAR T and lives on to here and gets some other complication like MDS, it may just be that they're alive. It's worth noting also that in myeloma in particular, that even in the transplant setting, even patients who get second cancers after treatment for myeloma, leading cause of death for them often is still the multiple myeloma. So I often tell patients that, look, with CAR T therapy, there are some unknowns about any type of gene therapy, and it is true that epidemiologically, patients who get CAR T appear to possibly, in some cases, be slightly higher risk of second cancers than those who aren't. But again, the myeloma is a much bigger threat for them at this point in time. And two, if you live long enough with a myeloma in remission, other complications may develop. That thinking and that framework, I think, is still very valid for most patients. However, this last month in New England Journal of Medicine, they published a case of what we would argue would be the opposite of the gold standard, the worst standard of something that truly probably is a scenario where the presence and the process of CAR T therapy did lead to this patient developing a malignancy. In brief, this patient developed diarrhea, loose stools, after receiving ciltacabtagene autoleucel, so commercial cilta-cel, that's commercial CAR T therapy for multiple myeloma. We have published work through the US Myeloma Consortium about diarrhea or basically loose stools after CAR T therapy can sometimes be enterocolitis. So it can sometimes be a CAR T driven process, not monoclonal, not neoplastic, cancerous per se, but a kind of a polyclonal infiltrate causing problems. Here, though, they did sophisticated gene sequencing. This was work done by Dr. Parika, senior author Dr. Cody at the Memorial Sloan Kettering Cancer Center in New York, and they were able to identify that this was a monoclonal population of CAR T cells. And furthermore, that the actual CAR, remember that CAR T cells require a CAR, a genetic sequence, to be introduced into the T cells, typically with a viral vector. That viral vector had inserted into TP53, which is a tumor suppressor gene, and by disrupting that, those cells automatically became destined to move towards cancer. I think it's a sobering case report, but an important one for our field to recognize. And I think it's important to discuss with our patients that, gene therapy does come with risks. And, up until now, the risks of gene therapy leading to cancers was largely theoretical in the modern era. It happened a lot in the early days of gene therapy for SCID research and so forth. It hadn't really happened this kind of a smoking gun case until now. Still exceedingly rare, right? Thousands of patients have gotten CAR T therapy around the world and have not had this happen, and have many of my patients, the vast majority of them that get CAR T are doing excellently years later. But I think this is important to bring up with patients that it's no longer a theoretical risk. It is a rare, but a reported risk here. There's a discussion to be had with them. I mean, I think at the bottom line, I'll tell you that most of my patients, every one of my patients, ever since this second primary cancer warning has come out, has still, if they need CAR T therapy, they've still favored going ahead with CAR T therapy because the cancer at hand now is a far bigger threat for most patients, for the vast majority of patients, than a theoretical cancer later. However, I think this is an important topic to bring up with them because, for example, bispecific antibodies may not have this risk, and for some patients may be equally efficacious for them, especially a combination of teclistamab plus talquetamab in myeloma, for example. And I think this is also a good impetus to revisit the idea of allogeneic off-the-shelf CAR T cells. We used to do a lot of research with them. There hasn't been as much research with allogeneic CAR T cells in myeloma and lymphoma recently. I suspect that data like this may start to change things because the idea is that if you can use healthy T cells and check where the gene is inserting with a fixed number of donors and a lot of good testing on it, that may lower the risk of this. So, in bottom line, how do I approach this discussion with patients? We've already been discussing the risk of second cancers with all of our patients with CAR T therapy. I think this is important because rather than describing it as a theoretical risk, as I had been doing for the last year and a half, now we'll describe it as a real, documented, albeit quite rare risk. Overall, the benefits of CAR T therapy absolutely outweigh the risks, particularly in the relapse refractory setting for patients with really any kind of cancer. However, I do think we need better research to identify how to prevent this from happening again with our autologous products, or as we go to allogeneic CAR T cells, seeing how to make this not happen, period, with them.